Well, I'm going to get started. We've got lots to talk about today, so thank you everyone for joining. Welcome to everyone's to the Ask an Expert session. So this topic is looking at digital mental health and collaborative care. So these sessions, as many of you may know, are designed to bring together three experts with different perspectives and backgrounds on an important topic of mental health. My name is Dr. Emma Wilson-Lemoine, and I'm a postdoctoral researcher at the University of Virginia. I'm part of the Thriving Youth in a Digital Environment, so TIDE, at UVA, and I'm based in Dr. Bethany Teachman's lab. So some of my work, I'm looking at acceptability and feasibility of implementing digital mental health interventions in real-world settings, something which emphasizes the importance of patient and service level buy-in. And as many of us know, digital mental health interventions that demonstrate efficacy in controlled settings don't always translate to adoption and sustainability in the long run. So with this in mind, I'm very interested in the topic of this Ask an Expert session, where we can have a discussion around some of the lessons that we can learn from innovations in collaborative care from our experts today. So the way that this session is structured is as follows. So I'm going to give a brief introduction to the three speakers we've got before asking each panelist if they want to add anything to what I've already mentioned, and also noting any conflicts of interest or relevant disclosures at this time. Then we'll jump to audience questions. So it's a very informal setup. So please post your questions in the chat, or feel free to raise your hand if you want to ask the question out loud. And then our session will end at about 3:50 Eastern time for a break. So I'm just going to get started. So I'm going to firstly introduce Dr. Caitlin Stamatis. So Dr. Stamatis is a clinical psychologist, Fulbright scholar, and expert in technology-enabled behavioral health. She has held various research, clinical research and product leadership positions within digital health companies. At Google, Dr. Stamatis builds a program of research on digital health interventions for trauma-exposed populations. As the Director of Medical and Scientific Affairs at Ackley Interactive Labs, her team's research resulted in the development of commercial product features for remotely measuring cognitive functioning in real time with a digital therapeutic. Currently, Dr. Stamatis is Brains Health's Chief Clinical Officer, leading clinical science initiatives focused on technology-enabled behavioral health integration. Dr. Stamatis holds leadership positions in several digital medicine organizations, including as co-chair of the Society for Digital Mental Health Industry Special Interest Group. She completed her BA in psychology at Columbia University, her PhD in clinical psychology at the University of Miami, and her psychology residency at Weill Cornell Medicine. So welcome, Caitlin. Next, we've got Dr. Khatiya Moon, who is a reproductive psychiatrist and early career investigator specializing in digital health, AI, and women's behavioral health, with a focus on perinatal mood and anxiety disorders. Her research leverages digital biomarkers, including automated speech analysis, to refine peripartum depression assessment and personalized treatment. This builds upon her experience in analyzing digital data, such as social media and Google searches, to identify mental health risks. Clinically, she serves as medical director of Northwell's collaborative care program, integrating behavioral health into primary care. She also treats patients at the Zucker Hillside Hospital Perinatal Psychiatry Center and educates clinicians statewide via Project Teach. Her leadership involves contributing to the American Psychiatric Association's Mental Health IT Committee, where she focused on ethical AI development. Dr. Moon has also served as a site PI for a digital therapeutic trial for suicide prevention, and her combined clinical research and leadership experience uniquely positions her to develop technology-driven personalized mental health care solutions. So welcome, Dr. Moon. And finally, we've got Dr. Jeong Youn, who is the Vice President of Product and Implementation at Reliant Medical Group, OptumCare, and is also on the faculty of the Harvard Medical School Department of Psychiatry. Dr. Youn is a leader in large-scale deployments of innovations in healthcare settings and also serves on the board as an advisor to numerous companies. So wonderful set of experts in the room today. Thank you so much for taking your time to be with us. So I'm just going to go around just to give each panelist 1 or 2 minutes, if you'd like, to add anything that I might have missed, particularly your connections to the session topic today, and also just noting any conflicts of interest or relevant disclosures. And then we will open up to questions. So I'm going to start with Dr. Stamatis, if there's anything you wanted to add.
Thank you so much for having me. I'll add just disclosures. So I'm actually, and I guess a bio update. So I'm actually now an employee at Otsuka. I receive salary from them, and want to emphasize that all opinions expressed here are my own. And I guess just in terms of relevance to this particular panel, I think is work I've done across, I would say, 2 settings. So the first is having worked in digital therapeutics at Achilles and now at Otsuka. We've focused on, I think, really trying to understand how do we communicate the value proposition of digital products to PCPs in primary care and collaborative care settings. And then probably most aligned with this, the topic for today is the work that I did at Bruin Health, where what we were developing was a clinical science algorithm that would enable behavioral health integration in primary care, really recognizing that the majority of mental health care is actually not happening with psychologists and psychiatrists, but actually by PCPs. So super excited to be here to chat with everyone, and thank you so much for having me.
Thank you so much. That's really helpful. Great to have you here. So I'm just going to move on now to our next speaker. So Khatiya, if there's anything you wanted to add to the introduction I already gave.
Yeah, thank you so much for having me, and good afternoon, everybody. I have no current financial disclosures other than my employment at Northwell Health, where I serve as the medical director of their collaborative care program. Just for context, I've been with that program for about 5 years in various capacities. So Northwell is the largest health system in New York State, and the collaborative care program that I help oversee employs between 20 and 25 care managers who are mostly master's level psychotherapists, CSWs, LMSWs, and LMHCs mostly, and supports 80 something primary care practices across Northwell's catchment area. And we're embedded in pediatric practices, adult internal medicine, family medicine practices, as well as OBGYN practices. And over time, we've tried to implement a lot of different kind of digital solutions into the collaborative care work to support it with varying degrees of success that I could speak about here. I've written a systematic or scoping review, rather, of digital solutions to augment collaborative care, which I could talk about here. And our whole health system right now is in process of transitioning to Epic from an amalgam of different EMRs that Northwell was using previously. So that's been interesting. And it's been interesting to think about how to build, Epic, the Epic system use the Epic system from scratch to kind of support our program. And I know that other health systems have done that as well, but it's been interesting to be in that hot seat. So that's the context in which I'm living at the moment.
Super. Thank you so much. Really helpful. And I think it really helps to get a bit of extra context for you guys. So thank you for these introductions. And then finally, Dr. Jeong. Dr. Jeong, is there anything you wanted to add?
Sure. First, Dr. Moon, good luck. Any HR change is a major undertaking. So, oh my goodness, that one statement was like, whew, so much work that you're clearly not sharing yet. Hello, everyone. Great to see you all. The only addition that I would add is I also am part of OptumCare as part of employment. So all views are my own and don't represent OptumCare, Reliant, or United Health Group. I think relevant to this panel, for the last 3+ years, I've been spearheading the development of a new behavioral health care pathway. We created an ecosystem of digital interventions. We partner with a lot of the digital companies that are experts in their own digital intervention and product. And our goal is to help match those to the patients in a personalized manner. So we've partnered with an integrated behavioral health department. We've also partnered directly with primary care providers, and we are in the process of building this ecosystem as an option for collaborative care. So excited to learn from everyone here.
Super. Thank you so much. Really helpful introductions. So just as a reminder as well, if anyone has any questions, you're welcome to add them into the chat or to raise your hand. Otherwise, I could maybe get kick-started with a question that I have for each of you. So yeah, and my question is just, let's define the space that we're working in at the moment. So when we're thinking about collaborative care, what does that mean to you? Just kind of, yeah, how you would understand that phrase.
Can I speak?
Mhm.
I think
course.
that's a really great question, a great place to start, because collaborative care is really one model in the context of a larger ecosystem of integrated care models. In other words, ways of integrating behavioral health services into primary care. And there's so many different ways to do that. And collaborative care is really one. It's not trademarked, but it's a well-established branded way of kind of doing that, but it's not the only way of doing that. What collaborative care is, can we pull up like I don't know, imagery or anything like that in this talk? If not, it's okay. But I usually use the triangle to kind of explain. So collaborative care is a model of care where there are kind of four main players. There's the medical provider at the top, the behavioral health care manager, and then the psychiatric consultant. And they all kind of work together to help the patient who's at the center of this triangle, if you think about it that way. So in collaborative care, the medical provider systematically screens their patient population for depression and anxiety using validated measures like a PHQ-9 or GAD-7, and then refers anybody who screens positive or has a clinical concern to the care manager, who can be a lot of different types of professionals. I mean, in the original trials, it was mostly RNs. I think in other studies, they've been therapists. So, there's peer people, right? So different people could kind of play that role. But the care manager is super important because they do a lot of different things. So they assess the patient, they do a needs assessment of the patient. They refer the patient to appropriate community resources if necessary. And they liaise with everybody in the situation, one of whom is the psychiatric consultant, to whom they basically present the patients, review the cases, and the psychiatrist provides treatment recommendations, including disposition recommendations, that are then relayed back to the patient and the medical provider, who remains the prescriber and kind of clinician of record. So there are a lot of things that could go wrong with this model. I mean, as you guys can imagine, even the whole first idea of systematically screening your patient population for depression, anxiety, right? What does that look like? Who does that? How do you get everybody in your, patient population to do a PHQ-9 GAD-7? So there are digital solutions that could come into play there. But every single step of the way, there are kind of pitfalls and things that go wrong. And I forgot to mention that one of the most important, components of the collaborative care model is a registry, a caseload registry that the care manager maintains, to basically track patients and make sure that nobody's falling through the cracks, and systematically review with their psychiatrist consultant those that are not improving or not responding to treatment. And the registry has really been established as a really important component of quality in this space. So yeah, that's just one model of kind of providing integrated care or integrating behavioral health services into primary care, but it's really been established in multiple randomized clinical controlled trials and in multiple organizations, medical organizations that have really championed this model as kind of best practice and an efficacious way to improve patients' not only behavioral health outcomes, but also their physical health outcomes, because we know that both improve when one improves. Yeah.
Thank you so much. That's super interesting. I don't know if anyone, one of the other two, if you've got anything to add, Jeong or Caitlin.
Yeah, I mean, I think Dr. Moon, you spelled that out so beautifully. I think from a, what does it mean to me perspective, going back to the question too, right? I think at least the space I was operating in startup land, so often VCs were focused on, and even some providers like, oh, we're unlocking new billing codes with these new collaborative care models, right? But it's really so much more than that, it's, I think, a mindset shift of like all of a sudden mental health is not this extra thing, it's embedded into the fabric of primary care. So it's not siloed, it's not treated as an optional extra. And I think aligns really well with this idea of like using the team-based kind of measurement-driven approach to treat behavioral health, just like we would any other chronic condition, right? Where it's systematic, it's proactive, there's accountability for outcomes in a way that I think historically there has not always been in behavioral health. And I think there's so much opportunity, right? There are obviously a lot of challenges and have been a lot of challenges in making that work in practice. And I think it's just exciting to think about the ways that digital tools can come in to make the model actually kind of work at scale, right? Of like, yes, with all the infrastructure that you were talking about, Dr. Moon, it's like, okay, maybe a doctor has 15 minutes with a patient, 5 others waiting, a million messages in their inbox. And, just, I mean, thinking about case managers, the scale of the patient load, right, that are placed often on care managers in these settings, I think that's where there's so much opportunity for I think tech to help with whether it's symptom tracking or kind of proactively identifying patient concerns that might come up. How can you communicate efficiently across the team? I think there's just so much opportunity.
I just want to highlight, I don't have anything else to add because the two doctors already covered in such specific detail, but I do want to highlight one common theme that both of them highlighted. This is a change. Collaborative care is not a common practice. Like if you go to your primary care provider's office, at least mine here in Massachusetts, like where it's progressive healthcare system, like chances are you're not going to see collaborative care. So and introducing the collaborative care model into primary care is a shift in how primary care operates. So I think a lot of the discussions that we'll have, I'm sure, as part of our conversations today in this panel, like I think it's helpful to have that context that if you're trying to apply, I'm not sure what everyone's primary care setting is like, some of the discussions and lessons learned that we're discussing here to that, there's going to be an extra step in the middle. Like this a lot of what we're talking about today is going to assume that implementation already happened or is in the process of happening in conjunction with digital layering. So just throwing that out there. And there are other companies out there that are helping this transition happen in the first place. So
I will say that although collaborative care is not commonly used or not nearly as commonly used as kind of guidelines suggest or say it should be, it is not new. It is not an innovative, radical, right? Like the original impact trial came out in, I believe, 1999 or 2001, so it's, and that was just kind of like a culmination of like a lot of other research that had already been done demonstrating the efficacy of similar models, if not exactly the same. So, I mean, there's been at least 25 years of research at this point, kind of demonstrating the efficacy of this type of work. So yeah, I mean, that just, I think you guys know that, but yeah, I just want to say that for everybody here, this is not a radical, it's not a radical model at this point.
That in mind, what do you see as kind of the biggest challenges? I know it's a difficult question to answer, but if the research's been around for a long time, what do you see as maybe the 3 biggest challenges to sort of embedding this as standard practice?
For collaborative care or digital in collaborative care?
Yeah, digital and collaborative care.
So, I mean, collaborative care is really in tension with it's a value-based framework, right, of healthcare, and that's really in tension with more of a fee-for-service model, which most health systems are kind of based on at this point. And so it's a little bit of trying to, I think the barrier, it ultimately can be summarized as just trying to fit a square peg into a round hole. Like it's not quite the fee-for-service systems that we have are not totally set up to support a practice like collaborative care. I mean, there's been shifts in that. I mean, Caitlin mentioned the advent of like the billing codes, the collaborative care billing codes, which have been, I think, great, for the adoption of the model, but still have, there's still challenges in kind of adopting it from that standpoint, I think.
Yeah, I think so. I think I mean, I'm thinking back to the kind of main challenges that we encountered trying to work in this space at Bruin Health. I think, one was I kind of three buckets in my mind. One was really with just workflow into like it sounds so obvious, but workflow integration of like, especially at a startup, right? You're not building, it's not going to be EHR integrated. And I think when there are so many tools, a kind of big barrier that come up would be like, oh, PCP says I have to log into another platform. Like already, and understandably so, because the administrative burden is already so high, visit times are so short. So I think it's this tension of how do you build a new product where, like, understandably, it's not going to initially be embedded into EHRs, and you need to get that data, show that there's some traction, but also get adoption in the meantime from providers who are already overburdened administratively. I think that's a challenge that came up. And then, like, related to that, just there are a lot of, I think, people trying to innovate with digital tools in this space, which is great, but there are a lot of sort of point solutions or like different systems that I think it's easy to feel overwhelmed, right? By maybe you have something, there's a point solution for screening, there's a point solution for care coordination, there's a digital therapeutic, right? Like all of these different things that are not talking to each other. And I think it kind of goes back to that workflow piece, I think, that came up as a challenge. And then, yeah, Dr. Moon, you touched on this too, but we ran into a lot of, I think, questions, challenges from providers around reimbursement too, of like, even if there are digital tools that improve outcomes, I think there can be challenges with getting reimbursed for them. Providers not being familiar with some of like 99484 or some of the collaborative care codes, how to use them. And I think without like a clear, without coming to a practice with kind of a very clear information on how to leverage some of those codes or how a tool aligns with those real world like reimbursement streams. I think that was a place where we ran into some friction initially.
And thinking about some of the facilitators, have you had any kind of, obviously we can do the flip side of the barriers, but are there any sort of experiences from your experience, sort of things that have really worked well, and what really helped that sort of with that adoption of the model into care, into their care practice?
Yeah, I mean, couple things I would say here. And again, these are not the things I'm saying are not really radical or new in terms of where the research has been, but in terms of implementation. So one thing is just virtual care and virtual collaborative care, which seems very simple. But our collaborative care program prior to 2020, we had care managers who were physically embedded in their practice, and so they saw patients from that one practice that they were physically embedded in. Now, post-COVID, post-2020, our collaborative care program is not fully virtual, but it's kind of a hybrid model, which is great because it means that we can cover a lot more primary care practices using one FTE, and as long as that individual has access to an internet connection, they don't have to just see patients who are physically coming into the practice where they have an office at. They can see a patient from any practice across the health system. So just kind of like virtual care, and the implementation of that has been, I think, a real important step for access and coverage. And it's not new. I mean, again, in the clinical trials, 2007 and 9, I believe, there were a couple of studies that came out from the VA, from the West Coast, looking at telephonic-based collaborative care model. So it's not, we're not telephone-based, we're video, but this isn't, the idea of telehealth and collaborative care is not new at all. The other thing that we haven't implemented it, but I've been curious about is this idea of kind of automated screening, which again doesn't seem radical in 2025 and doesn't seem new, but there was a number of studies that came out again, like I think 10 years ago or something, looking at interactive voice recording as a way to collect PHQ-9s and GAD-7s, which are so important to the implementation of collaborative care and to effective collaborative care. And this group was like putting out all these studies about interactive voice recordings as a way to collect those assessments. And it was so interesting because they found that patients who had a high degree of mental health stigma, in other words, who were, kind of averse to the idea of seeking mental health treatment were actually more able, or like had a higher engagement with the interactive voice recordings, or with the kind of like automated collection of PHQ-9s and GADs. And I think that's really interesting because, there's a way in which we might, we always worry about kind of like AI safety and stuff like that, but there are people for whom these kind of more automated ways of seeking mental health access might be easier to stomach or, go with than actually talking to a person about it if they have a high degree of mental health stigma. So I thought that was really interesting. I mean, obviously in 2025, we're not gonna be doing interactive voice recordings. It's probably going to be like a bot, but whatever. But it's just kind of an interesting thing to think about.
I think the other thing, if we continue in the spectrum that the two of the speakers already kind of laid out, post-screening, let's say everything goes well. The screening goes great, the matching with the case manager goes great, and then we reach the challenge of treatment delivery. We still, right now, the models usually assume some sort of human person doing some sort of behavioral health delivery. I think that's where some of the digital tools and therapeutics that are available that do that kind of treatment delivery portion can also come into play to really expand the spectrum of patients that can be served differently. Maybe the mild to moderate patients don't have to be seeing a human person right away or for the whole course of their treatment. Maybe they can be supplemented by using and having some treatment delivery done through digital tools, either as a self, I'm using the tool myself, and then I check in, or maybe I don't even check in at all. And this is like my first line of defense, quote unquote, and then I'm good to go because I'm feeling better and I don't need to check in with somebody. That frees up human, quote unquote, time and resources that can then be allocated to other patients that may need some sort of hybrid or may actually just need a human. So it can, if we underlie all of this magical tool that somebody will probably figure out at some point, that can figure out all the billing and can figure out how do we then allocate, payment appropriately so that those digital tools can be covered and the time and blah, 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 then you can really start to make a dent. Because I think it was our keynote speaker today that was discussing this as a key important factor for us to think about as we move forward. How do we integrate digital interventions and tools and therapeutics as a way to really scale, not just, fix, quote unquote, our healthcare system, but really be an expander of our existing healthcare model in certain ways. And this could totally be one of those.
Thank you. Super interesting. Thinking about it from the kind of patient's perspective, have you done any work to try and understand sort of how does this fit in with sort of patient acceptability in terms of either their outcomes or just, is this something that they're on board with as well? As we know, that's very important for any kind of implementation to be successful in the long term.
Are you talking about digital tools or collaborative care in general?
It can either, yeah, you're welcome to answer as you wish.
Yeah. It's really interesting. I mean, I think patients, and I'm not as familiar with the qual research in collaborative care. There have been focus groups and stuff like that, to try to understand the patient perspective in collaborative care. I'm just not as familiar with that line of work. I think it's really interesting because our model, we provide time-limited psychotherapy in our collaborative care model, so 6 to 8 sessions. And I think it's been really great for some patients. There's patients who just kind of love the idea when a primary care provider tells them like, hey, it sounds like you have some anxiety. Would you like to speak to our therapist who can do kind of like this time-limited psychotherapy model? And they love it because, they don't have to see somebody outside of the office, somebody in like a scary behavioral health space that they're not comfortable with. They don't have to be in therapy for the rest of their life because it's 6 to 8 sessions and they know that off the bat. And, they still kind of get to, and their PCP, whom they trust, is kind of, warmly handing off to this individual. I do think there are patients who, don't like that. Where like, they like the idea of going to a separate behavioral health space or provider, either because they value the confidentiality aspect and that's really important to them, or they just have kind of a certain idea of what behavioral health should look like and this isn't it. or they really don't like the idea of time-limited care. They don't want to be limited by, somebody else's timeline. They want more, or they're just kind of looking for something else, like a more exploratory psychotherapy or something that's more open-ended. There are people like that, and a lot of people like that. And I think, that collaborative care doesn't always meet the need for those patients, although it can be a good kind of like entry point, I guess. So yeah, I mean, in terms of digital solutions that patients, I think it depends on what it is, like the type of solution that Dr. Youn was talking about, where a conversational AI or something like that deals with more mild to moderate cases or provides that kind of support for milder cases. I think some patients might be curious or interested about that, but I can see a lot of patients not wanting that. I mean, collaborative care, the goal of it is already to kind of give, it's already a very low level of care. So I guess I would struggle with whether or how to dilute it kind of even further, or like how do we do that safely, which isn't an insurmountable thing. It's just something to, I guess, think about in this space.
We've published on this model quite a bit, so I'm happy to send Emma papers out if the audience members are interested. So Dr. Moon, just to clarify, I think conversational AI, it sounds like we're, jet rocketing to that. But I think there's also a lot of solutions out there available right now that have evidence that don't even are AI based. So our ecosystem right now includes a diversity of different digital tools, and some are digital therapeutics, some are not, some are considered wellness tools, and they range from like device-based things, literally, to smartphone apps, VR headsets, and everything in between. And our papers we have them publicly available, so I can talk about them. They show that patient acceptance is quite high. The biggest initial hurdle is provider acceptance, actually. Providers are pretty hesitant to the idea of like, wait, so you're not only asking me to think about and do something with behavioral health, but then you're also asking me to talk to the clients and give my patients like actually something that is not a human person to address their behavioral health. There's a lot of resistance and concern, adequately so. So I think it's like the end users, like, again, this was also discussed in an earlier conversation today. We have to think about multiple end users as we're thinking about how do we integrate digital interventions into an existing healthcare setup. And it's not just the patients. Of course, the patients are the end users that we always most care about. But also in between that, if we're going to be leveraging healthcare as a conduit to get patients access and not a direct-to-consumer approach, then you have to think about not just the primary care providers, but the operations people that are supporting the primary care providers, like flows, the nurses, like what are their roles, if any, like what about the front desk staff, who are the people that are going to be administering, like again, like Dr. Moon was saying, the screening tools, all those, everyone involved in the care of the patient. And the model that we started to build, like actually was built in conjunction with primary care providers to make it actually flow and be integrated seamlessly. And the acceptance, adoption acceptance, and also outcomes show that we're doing a pretty good job. And if anything, because our model doesn't imply this one-size-fits-all digital approach, we have an ecosystem on purpose. Like, people are different. Like Dr. Moon is saying, some people are going to be like, yes, give me all of it. And we're hearing that. Like, I don't want to talk to a person, like, but I don't have to, great, give me what it is. Other people are loving it because they can adjust to like I can't just go to a 1 hour a week and have to make that appointment, even if it's a virtual thing. They want to be able to talk to somebody at like 3 in-the-morning, just like we were hearing early in the session at noon. So, and then there are going to be also patients that are like, no, not for me, thank you. So there's having the variability of options is what's going to help purposely and biasly match the patients to the right treatment so that we can maximize outcomes. And that's what we found in our work.
Yeah, I think we found very similar, kind of very similar sentiment from on the patient side in our work, kind of user research with Bruin Health, and 2 points that the two of you made that I think are wanted to kind of touch on one that you said, Dr. Moon, around that warm handoff. I think it's especially essential with digital tools. And I think part of the reason we had pretty high engagement, so with Bruin Health, when deployed in, real world settings, right, in these contexts, I think it was about 75 to 80% of people who were assigned the initial kind of evaluation actually completed it. And in doing like user research, talking to patients, talking to providers, it really was because their PCP or right, like a provider that they had a trusted relationship with was suggesting that this would be something that was useful to them. And I think it's similar around, in that recommendation piece of absolutely, I think we should be triaging some people who might prefer to have a digital therapeutic or a wellness tool, right? Like, or have lower symptom severity and don't necessarily need the like higher touch care to digital tools. And I think, just understanding the confusion in general among providers too, of like, what are digital therapeutics? I think we have like the onus is sort of on us, right, at digital health companies to be doing a lot of that provider education around like what this is, how to set expectations with patients, because ultimately I think it is that conversation with the trusted provider that's going to make the difference in whether someone follows through on a digital recommendation that could be a really good fit for them, and perceives it as like sees the value in it and sees why, oh, this isn't like a watered down version of something, or this isn't, a not as good option. This is the right option for me. But it's that conversation that has to happen. And I think it goes, I see David's on the call too, right? Like it goes back to that, all that work around coaching and digital tools and how, having just that light human touch supports engagement. I think in our anecdata, right, our user research, that was just borne out time and again, whether it's support from the PCP, support from the patient, just some type of human follow-up, I think it is essential with where we are right now.
Thank you. And just kind of touching on something you mentioned earlier about kind of the barriers, thinking about the sort of workflow challenges, I think a few of you have mentioned. Do you have any ideas of ways to kind of improve the workflow challenges in primary care? Thinking about either digital mental health or collaborative care or both.
We'll see if Epic is the magic solution.
It is not. It is not.
Yeah. I mean, I think system interoperability is a really important piece of it. And I mean, others have touched on it. Collaborative care is such a complex model because there's so many players involved and they all have to really have excellent communication and relationships with each other for this to really work. That if your technology systems don't support that very well because they don't talk to each other, or they're, then the collaborative piece of collaborative care just sort of breaks down. I mean, I don't think it's an accident that a lot of the, initial clinical trials occurred at the VA where everything's just kind of in one system. It's sort of a closed system model. I don't think that's an accident that it worked really well there. I think it's, the more complex the system is technologically, the more complex those relationships become as well.
Yeah, I mean, I think a lot of it is just around optimization, right? It's not going to be, I think the tools that are going to have the most digital tools that I see as being potentially the most impactful from the kind of seeing how some of these clinics were operating is they're not necessarily going to be the coolest, most novel things. Like a lot of it might be around, I don't know, taking the parts that are really manual and kind of fragmented right now. I think going back to this idea of screening, if that can be automated, or kind of triaging, right? If knowing that a lot of times there still are wait lists within those models and systems to get in with a behavioral health provider, like who can go to digital tools first? And if some of maybe it's like, save the AI chatbot for now, like if we can use AI or some of these large language models to help out on the front end of that process as people are coming in and understanding what's going on with them, understanding that like risk stratification a little bit better, I think there's a lot of opportunity to optimize the process there, make it more efficient. And then, tracking outcomes, tools that will help out with billing and kind of documentation, right, for reimbursement. I think a lot of that is immediately needed, and it might not be as like fun, but it's, I think, stands to have a lot of impact on the system.
I think the bar has to be very high for change, is the way that we think about it. Like one click is one click too many. So I think with that mentality, I think it's helpful to think about all of these. I think are foundational things that Dr. Moon and Dr. Stamatis have said. But even as we're thinking about, okay, how do we then get the users to interact with this? Let's say that the setups are great and they work perfectly, no glitches, never, all set up, ready to go. It's still one more click, two more clicks. It still makes a humongous difference as to whether they're going to adopt it or not. And then the other, I think, thing to think about is we I think try to solve for how do we optimize all the time. And I think like there should be a bifurcation. Like some things, the providers want optimized, like the stuff that like they just live with it because they have to, it just comes with the responsibility in the job description. But there's some stuff that like they're not ready to have optimized 100% in certain ways. So I think understanding where the divide lies, so that the pieces that are just really potentially low-hanging fruit, that might not be the sexiest things to do to change, and like, wow, that is so cool to introduce, but that might be what gets you going to getting the providers buy-in first, so that you can continue to add more things to support them and continue this longer term scaling game, quote unquote, and change mostly.
And in any of your conversations, Dr. Youn, have you found kind of things that the providers maybe don't want optimized? Are there certain things that you're coming?
A lot of the providers that we've talked to, they are, at least what they've shared with us, is that they're not ready to have somebody else like take over clinical judgment. I think clinical decision support should, the word that is like that should be highlighted, bolded, and sprinkles around it it's support. Like they want to trust their gut first. They want to be able to make the final judgment around like what is the optimal best way to care for the patient, and that they don't want to have that taken away. They want support to be able to consume. I have 20,000 things that I got to read in order to make this judgment. Like, no way. But like, show me how to like help me make this judgment myself and support me rather than do that for me and then make me action on it. So that's it's a subtle difference, but it's a key difference that will help them guide what to integrate, like what to digitize, what to optimize for, and it can have really differences that impact on provider and provider adoption. And the same logic can be applied to, again, I know we're focusing a lot on primary care providers here and they get the brunt of it, but the operations team that is side to side with the clinical team, there's a lot of work to be done there too. And similar thinking applies there too.
Super. And actually thinking about some of the other sort of key sort of service level stakeholders in this conversation, like what do you think are some of the things that are coming up on the operations side as some of the sort of barriers and facilitators to kind of implementing collaborative care models?
Yeah, I mean, I think billing is a big one, and having, you know, appropriate documentation to support billing. In New York State, we were partially funded by the Office of Mental Health by the state, and they require all these kind of like quality reports that have all these different metrics on them and stuff like that. So automating things like that would just free up so much of our administrative time to do other things. I think from a clinical, you know, from the clinician's perspective, I totally agree with Dr. Youn, and that I think that I relate to that of being really worried as a clinician about you know, the tools taking over clinical judgment, or even those kind of decisions of triaging people to tracks. You know, I worry about that. And at the same time, I'm much less worried about things like AI scribes, right? I think that's why there's been a lot of excitement about those kind of interventions, because it's like clinicians hear that and they think, oh, a technology that's going to make me do less stuff? Huh, okay, that's a new one, right? I think there's been so much the average clinician who's not plugged into technological advancements or anything, they're just trying to survive and get through their day. Their experience of technology in clinical care has basically been, like what Dr. Youn said, more clicks, one more thing for them to do or keep track of or understand. And so, you know, the idea of a technology that actually takes something off their plate is a little bit like scary, but I think is something people are kind of yearning for at the same time.
Yeah, I think that's such a great point. And you know, it's definitely it's definitely framed, at least for us, right? I think when we framed the conversation with PCPs who are interested in collaborative care, but you know, couldn't afford to hire, right? Like couldn't hire a social worker to support their client, right? Or wanted to kind of start to explore behavioral health integration and needed support doing that. It was, I think the sort of talk track that seemed to resonate was like, you're doing a lot of this work right now, but you don't have the documentation to get paid for it, right? Your patients are coming, 70% of primary care visits involve a behavioral health component. We know that, right? That's a stat. So you're already screening people for depression or talking to them about their depression. You're already managing their symptoms. Like they're, I think, relatively straightforward tech-enabled ways that could support, kind of augment the way that this is happening so that you can then take advantage of some of these care codes that, you know, reflect the work that you're doing. So I think that messaging around like helping providers get credit for what they're already doing through some of these tech tools is at least something that resonated with a lot of the providers that we spoke with, especially those working in fee-for-service contexts where they have so little time to do so many things. And I think on the operations side too, talking to like office managers, I think when there was always concern about like, okay, well, if we're doing more things, does that mean like who's going to do it, right? Do we have to add head count? Like who's going to do the screening? How does that happen? So figuring out if it's I think it all goes back to the not asking people to do another thing and instead showing, demonstrating how these elements, you know, you've thought about them, you've kind of designed whatever tool this is in a way that has each of those stakeholders' perspectives in mind. To go back to Dr. Youn's point around, you're designing for a whole lot of different people when you're designing tech for collaborative care. And I think for the office kind of back office task, it's critical to show how this will alleviate burden and not add any other things.
I think like it's when you talk to providers, and ops leads, the ratios that they think about or the percent of what they're trying to solve for is different. Like providers are what is going to help most of my patients, like 60, 70, 80%. Ops leads, when they're trying to solve for change, is actually they're trying to solve for the 30% that is not going to be captured by the majority that the change is here to address. So their brains are geared towards like fixing on like all the like exceptions. Like, okay, well, you're saying that this change is going to come in great, so that will maybe address 60% of the patients. What about the 40? And their brains go to that. So what they're emphasizing and they're thinking of and they're prioritizing as a thing that they need to solve for is very different. So I think keeping that in mind and trying to come up with a solution that is going to have to address to both of these two needs is absolutely important to have from the get-go. Otherwise, most implementations will go to not be anything else than a pilot after the first 3 to 6 months.
Yeah.
That's pretty quickly when you know it's just not going to work. So
Thank you so much. So I've got one more question. Conscious of time, it's already flown by. So I'm just going to read out the question if one of you or a couple of you want to jump in. So this is from Dr. Moran. So many areas, especially rural areas, face severe behavioral health workforce shortages. Are any of you using digital therapeutics for patients on treatment waiting lists?
I mean, I think in part collaborative care is supposed to fill that gap of kind of bridging people to their, you know, appointment at the community behavioral health center, which is 3 to 6 months away. So I think collaborative care for places where it exists is supposed to be kind of that bridge or interim solution. My understanding is, I mean, we have somebody on here from Otsuka, so maybe you might have more to say about digital therapeutics, but my understanding of a lot of digital therapeutics, at least as they're currently conceived, is that they're meant to augment treatment, not replace it. So if you sort of like don't have any treatment at all going on, then it wouldn't necessarily be appropriate to use. And then if you're not using a digital therapeutic, then you're kind of in the realm of like sort of unregulated wellness products or whatever, you know. So that brings up a whole other set of questions. I'm not exactly sure if that answers it, but
yeah, I mean, that's a whole other, right, like a whole long thing. But I think, so there are some digital therapeutics are standalone treatments. So Kill Endeavor RX, Endeavor OTC, those are FDA authorized for the treatment of attentional problems in ADHD as standalones. Versus Otsuka, for example, has Rejoin, right, which is FDA authorized as an adjunct to antidepressant treatment. So to your point, I think that is an implementation barrier. And again, this is my perspective, just me, right? Not the companies necessarily, that this is, I think, a challenge of like thinking about many patients who might benefit from something that is ultimately a cognitive behavioral treatment combined with like cognitive emotional training. And as a psychologist, like could see the value in that for a lot of different folks in a lot of different settings. But if it needs to be prescribed alongside and in someone who is already taking an antidepressant, that introduces a potential barrier to care or kind of friction in the process. So I think that's a challenge that a lot of digital therapeutics companies are trying to figure out, like how to kind of make those experiences and kind of access points a little bit more seamless. There are examples, though, I think of digital therapeutics that have been used in the context of, wait list management, right? Recognizing that sort of has been the one way in which I think they could add a lot of value is in giving access to these treatments for folks who we know are seeking them, but might not be able to get them right away. I know Silver Cloud has done this, right, with the NHS. I think it was in a kind of like a waitlist bridge in rural communities and saw pretty solid uptake, right? A lot of activations in use of their like coach supported digital CBT for depression. So at least one example that I know of a way that digital therapeutics have been used there. And I think there's so much potential. It's just, again, the implementation piece and kind of these access points that we need to figure out.
I'll throw in one more thought to that. Our experience has actually been a little different. The moment when the patient has been put in a wait list, they have made their choice on treatment. The optimal treatment for me is a person for me to receive my behavioral health care. So our experience has been that, like, even if we reassure the patient, we are not taking you out of the wait list. Like, you're gonna have to wait the same amount of time. Doesn't matter what time that is. Patients are either reluctant or it does not make them not seek behavioral health treatment with a human after the fact. So it actually does not do that offset that you're hoping for. Like if your symptoms are addressed earlier, ideally you will not need the human person later. Our experience has been actually not the case. Adoption has been very, very low. And even if like you actually digitize and show you, like, we are not taking you out of the wait list, like people are like, I don't believe you. So and a lot of the conversations that we have with the patient is like, you're giving me suboptimal treatment option. Like, why would I take it? So and even if I do take it, is because I know that I'm going to actually then go see somebody else. And this is like a little bit of a bridge for me, but it's not going to really do very much for me. So I think it's really to add to the implementation challenges that Dr. Stamatis was saying earlier, like it's thinking about also the patient characteristics, like what are the belief systems as they're waiting already, because their choice of what is the treatment preferred option has been made already at that point. So, and they're willing to wait. So that's not, they're fine. As providers, we don't agree with that. They shouldn't wait, but they're fine. So.
Great discussions, everyone. I really appreciate you coming to speak to us today. I'm conscious of time, letting you go, but thank you so much to our expert panelists for your time, and I've definitely learned a lot today. So yeah, thank you, and I hope to see you in another session.